First of all, I would like to thank the organizers of New Colloquium for giving me this opportunity to talk about a very important topic, which is neonatal cholestasis. So, I will be discussing the topic under the headings of introduction, definition, and epidemiology of neonatal cholestasis, differentials and etiology of neonatal cholestasis at international level and in Pakistan, evaluation of neonatal cholestasis and its management, and then I'll share at the end our experience from Children's Hospital Lahore. So, neonatal cholestasis is defined as prolonged conjugated hyperbilirubinemia, which is more than 1 milligram per deciliter beyond the first 14 days of extrauterine life, and it may present at birth or within first 3 months of life. And it approximately affect 1 in 2500 live births. Unfortunately, we do not have data from Pakistan, but we published our paper in 2017, which showed that the neonatal cholestasis constituted around 30% among all the hepatobiliary disorders. And almost the same percentage was published from our neighboring country, India. It's around 27 to 33%. Neonatal cholestasis remains a great health problem because of delayed diagnosis with high morbidity and mortality. Biliary atresia has been considered the most common cause of neonatal cholestasis worldwide, followed by other monogenic disorders. With the availability of genetic analysis, the number of idiopathic neonatal hepatitis is decreasing consistently. So, what is the most common cause of cholestasis in an infant? What does the world say? You can see over here. This is the European study which showed that the biliary atresia is the most common cause, and while in the USA, this is again the biliary atresia is the commonest cause. So, across North American and European, 40% of cholestasis cases in newborns are caused by a fibroinflammatory condition, which is biliary atresia. In Middle East and Saudi Arabia, this is the study done, published recently in 2021 from Saudi Arabia, which showed that the genetic metabolic causes, genetic cholestasis is more than the biliary atresia. This is the paper what I was talking about, and the data was between 2014 and 17. And you can see over here that the idiopathic neonatal hepatitis and the biliary atresia were the commonest condition among the neonatal cholestasis. But after having the facility of genetic analysis in our institute, when we compiled our results in 2021, we had this genetic cholestasis and metabolic liver disorders more than the biliary atresia, which constitutes around 62% of this cohort. So this is the snapshot taken from on a single day from our liver unit, which shows these all mothers are carrying their children for the assessment of neonatal cholestasis. So the basic aim of evaluation is to correctly and timely diagnose and differentiate prolonged physiological jaundice or breast milk jaundice from cholestasis. So what the NASPGHAN guideline says, what Professor Asim Makbul has already said, any neonate who is jaundiced at 2 weeks of life on formula feed or 3 weeks of life and on breastfeeding shall be evaluated with fractionated bilirubin. And the second basic purpose of evaluation should be any medically treatable or life-threatening condition should be managed on priority basis. And if any child requires surgical intervention like biliary atresia, he or she should be dealt within the appropriate time. So after taking the detailed history and physical examination, including the prenatal events and infant details, this is the most important aspect in the evaluation. This is the stool color card, and one must need to differentiate between the normal and the abnormal. So this is the abnormal stool color and this is the normal. So this must be seen by the physician himself or herself. So if the physician finds this the pale stools or clay colored stool, the investigative approach should be expedited to rule out the possibility of bilirubin. So next comes the appearance. Is the child well or sick or in acute liver failure or has any dysmorphic features? I put this urine reducing sugars over here because whenever we receive the neonatal cholestasis children in our department, we do it on the bedside just to have an idea about the galactosemia, which is one of the most common disorder, metabolic disorder in our society. So this is a well child we received in our unit at the age of 2.5 months and having history of jaundice since first week of life with pale stool, firm hepatomegaly and spleen palpable 3 centimeter below costal margin. Bilirubin was 12 milligram and with the direct fraction of 7 milligram. High gamma GT and ultrasound showed atretic gallbladder. So what should be the sequence of investigation in this child? So is it the HIDA scan or liver biopsy or the peroperative cholangiogram? If we go for the HIDA scan takes a little time. It's a time-consuming modality which needs priming with phenobarbital. And if we go for the liver biopsy, again in our circumstances, it takes a little time for the interpretation. So in this child who is already 2.5 months old, having all the markers pointing towards the bilirubin, we need to go for the peroperative cholangiogram. And the peroperative cholangiogram, in this child, we performed the peroperative cholangiogram and it showed the bilirubin and the portoenterostomy was done and the child is doing well. So these are the conditions where you find these children usually are generally well. So this is the algorithmic approach for neonatal cholestasis. If you find a child with direct hyperbilirubinemia of more than 1 milligram and he is healthy in appearance, go for the first line investigations. And this is the first line investigation, which is the basic investigation should be done in all the children with neonatal cholestasis. If these investigations point towards the diagnosis of bilirubin, then go for the operative cholangiogram. And if the bile duct are not patent, go for the portoenterostomy. But if the bile ducts are patent, like in this child, you can have a fair excretion of the dye into the small intestine. So then you need to proceed for the second line investigation. And these investigations are more directed towards the specific cause. So this is a algorithmic approach for non-bilirubinemia children. If the child is acutely ill or in liver failure, then you need to consider more of infective etiology like bacterial or viral infections, metabolic liver or severe birth asphyxia can have this presentation, metabolic liver diseases, inborn error of metabolism, and genetic cholestatic condition. And in this scenario, like we received this child in our unit at the age of 2 months, having history of jaundice since first month of life, exclusively on breastfeeding. And this child had history of onset death in early infancy with similar illness. He was sick on examination, jaundiced, having ascites, hepatosplenomegaly, and cholestasis with deranged liver functions and element of acute liver failure. So we did the urine reducing in this child and it turned out positive. This is the normal color of urine reducing, which is negative, and this is the positive urine reducing. And the genetic testing also confirmed the diagnosis of galactosemia in this child. This is another sick child who was received in our unit who has short history of jaundice for 3 weeks. He was pale, jaundiced, having hepatosplenomegaly with ascites. Urine reducing was negative in this child and there was cytopenia on CBC with conjugated hyperbilirubinemia with deranged liver functions and disturbed coagulation. In this child, we performed the second line investigations which showed the high serum triglyceride and ferritin was also high and the bone marrow biopsy shows the hemophagocytic syndrome, hemophagocytosis. So an acutely ill children with or without liver failure, we need to consider the septicemia, viral infections like the herpes, gestational alloimmune liver disease, galactosemia, tyrosinemia, fructosemia, and hemophagocytic syndrome. There is a long list, but these are the most important investigations you need to consider in these children. If the child is not very sick, you can go on this side and you have the availability of gamma GT, then either they are normal or they are increased. So these are the conditions mainly come under the category of genetic cholestatic conditions. So this is a child neonatal cholestasis with high gamma GT, then you need to consider progressive familial intrahepatic cholestasis type 3, neonatal sclerosing cholangitis, Alagille syndrome, excluding bilirubin and other obstructive causes. This is the cholestasis with low gamma GT, and in this there are only few conditions which presents with low gamma GT, and the prototype is progressive. All the types of progressive, there are 5 types documented in the literature, and all the types presents with low gamma GT except type 3. Bile acid synthesis defect, ARC syndrome. ARC syndrome is arthrogryposis, renal tubular leak, and cholestasis, and the panhypopituitarism. The syndromic causes of cholestasis are rare, but we do see in our practice, like Alagille syndrome, ARC syndrome, Zellweger's, and trisomies, with multisystem involvement and pertinent facial dysmorphisms. This is the list of investigation, first line and the second line, after having detailed liver functions including gamma GT and looking at the child is in the synthetic liver functions, and this is we need to go for further. And the second line investigations are directed more towards the specific pathology. So I will be discussing a little about a few modalities in the radiology and the few investigations which are coming up in the literature for specifically for bilirubin. So ultrasound abdomen, which is readily available, non-invasive, and it can give you a fair idea about the echo texture of liver, obstructive pathology, size of the gallbladder, and about the bile ducts. HIDA scan, what I have just discussed, that it's a time-consuming modality, and it has high false positivity rates and require a little 3 to 5 days for priming with the phenobarbital. So usually it is not very recommended. But recently a paper, I just forgot to mention the paper over here. It is said that whenever the bilirubin goes up, the yield of the HIDA scan comes down because of the excretion and the liver the severity of the liver disease. Next comes the MRCP. MRCP is a very good modality in reference to to see the ductal anatomy, but due to the technical difficulties in small children having deep sedation or general anesthesia, and in the first few months as the ductal anatomy is not very clear, so this is not a very recommended modality in neonatal cholestasis. Then comes the ERCP. Same is true for the ERCP because of the deep sedation, general anesthesia, and unavailability of neonatal scopes and accessories for ERCP is difficult to perform and only being done in only few select centers. So the intraoperative cholangiogram and histological examination of the duct remnant is still considered the gold standard for the diagnosis of biliary atresia. So, liver biopsy is one of the most important and helpful diagnostic modality, especially in cases of biliary atresia. It is also helpful in other cases like progressive familial intrahepatic cholestasis, bile duct paucity syndromes, and like the CMV inclusion bodies in the CMV infection. And it also tells you about the degree of fibrosis. In a paper, this paper which was recently published, the diagnostic accuracy of different methods in diagnosing bilirubin was as follows. The liver biopsy had the maximum yield in diagnosing the bilirubin. In the recent advances, I put the stool color card over here. Although it's not a recent advances, this stool color card scheme was used way back in 1990s in Japan. But the lead was taken by Taiwan and implemented as a screening tool between the period of 2002 to 2004 nationwide, and the results were very significant in reference to like picking rate for bilirubin and reducing the burden on liver transplant. It also was associated with decline in the proportion of late referral. So recently, a pilot study was published from Egypt, this one, and this showed that the stool color card proved to be a simple, efficient, highly sensitive, specific and applicable method for early diagnosis of biliary. Fibroscan and elastography has been in use in adults for decades to just score the fibrosis score. People now are interested in looking at the this elastography using the transient elastography to score biliary patient. And in a study done from Taiwan using this transient elastography in 48 cholestatic infants, among them which 15 had biliary, liver stiffness above 7.7 kPa predicted biliary. Researchers are also trying to have some non-invasive way of diagnosing bilirubin, and one of them is matrix metalloproteinase 7. It's a protease and causes bile duct injury which leads to liver fibrosis. An optimal cutoff value of 18.6 nanogram per ml for serum MMP7 in diagnosing bilirubin had a sensitivity and specificity of 190% respectively. In another study, it showed that the plasma matrix metalloproteinase 7, interleukin 8, and gamma GT combination has a good accuracy to differentiate biliary from other cholestatic condition. Similarly, interleukin 13 has also it appears to be overexpressed in bile ducts of patients with biliary, leading to a proposed use of serum IL-33 levels to differentiate biliary from other cholestatic conditions. This is another novel approach to look at the telangiectasias on the liver surface, this one, and the arteries and arteriolar dilatation. And this has this is just the mentioned study over here, and in this study they mentioned that it has a very high accuracy rate in diagnosing biliary. The recent advances in the genetics has changed our thinking and approach in neonatal cholestasis, and the current algorithms models use genetic testing earlier in the diagnostic evaluation for neonatal cholestasis once the biliary and treatable conditions are ruled out. It's a little rapid and affordable molecular diagnosis for disorders that cannot be directly diagnosed from standard blood test or liver biopsy. Early identification of a genetic cause guides medical therapy and sometimes informs decisions about referral for liver transplant. Like if you have a PFIC type 2, so they usually present with early liver failure requiring liver transplant. And available next generation sequencing techniques include targeted panels, whole exome sequencing, and whole genome sequencing. The management plan is the medical treatment and the surgical treatment. These children use nutritional support, treatment for the pruritus, management of chronic liver disease and its complication, and surgical interventions are Kasai procedures, excision for the choledochal cyst, and the liver transplant. The nutritional support, these children require a high calories for their growth, and their formula should be supplemented with medium chain triglycerides, and they should be supplemented with fast soluble vitamins and water soluble vitamins. And if there is any metabolic liver disease, it should be replaced with the specific formula. The specific treatment should be managed for the underlying cause, like the potoenterostomy for bilirubin, antibiotics for the sepsis, antiviral for the viral infections, thyroxine for hypothyroidism, and cholic acid, which is the drug of choice for bile acid synthesis defect. Although it's not available in Pakistan, but we are getting this from on charity basis from outside. Nitisinone is recommended therapy for all for the tyrosinemia patients. Even if they are cirrhotic, this is recommended, and it can reverse or stabilize the liver disease. Treatment of pruritus includes the conventional medication, including the antihistamine, bile acid binders, ursodeoxycholic acid, phenobarbital, and rifampicin. If they are not being controlled with these medical measures, biliary diversion can be helpful. There are few newer drugs for pruritus, which is the ideal bile salt inhibitors, Bileway and Livmerli, and they were actually introduced recently in the Western market for the treatment of pruritus in progressive familial intrahepatic cholestasis and Alagille syndrome. Management of portal hypertension and its complication includes the varicose bleeding, and usually we do the endoscopic procedures, sclerotherapies, or endoscopic varicose ligation. And if they are not being controlled on these endoscopic procedures, we can send them for the portovenous shunting. For the ascites, sodium restriction, diuretics, albumin, and paracentesis are required, and ultimately the liver transplant if the patient is having end-stage liver disease. These are the few emerging drugs for liver disorders in reference to neonatal cholestasis. There is a great deal of interest in developing novel therapies to reduce inflammation and fibrosis in pediatric as well as adult cholestatic diseases. So there is a drug which is under investigation, nor-ursodeoxycholic acid, which has more stronger cholinergic effect. It also has an anti-inflammatory, anti-proliferative, anti-fibrotic role. The next is the farneside X receptor agonist. The farneside X receptor is actually the major molecule regulatory hormone which down regulates the expression of bile acid synthesis and up regulates its efflux. So reducing the bile salt concentration and relieving the pruritus. And there are other potential chaperones such as phenylbutyrone for selective cases of progressive familial intrahepatic cholestasis type 1 and 2. But the people are working on gene editing and gene transfer strategies as potential cures for genetic causes of cholestasis, and it may revolutionize the treatment modalities in future. So I'll be sharing our experience from Children's Hospital. This is a 3-year study, and the basic aim was to look at the frequency of genetic inherited cholestatic disorders in Pakistani children. So this was done between the period of 2019 and January 2019 and December 2021, and children with cholestatic liver disease on the basis of their clinical, biochemical, radiological findings were included, excluding the bilirubin and torch infections. Low and high gamma GT cholestasis with the presentation of chronic liver disease, acute liver failure, and end-stage liver disease patients were recruited. And their blood samples were sent for the whole exome sequencing. And this is we sent around 398 patients sample, and 158 patients were positive for monogenic defect. So it is around 40%. And there are around 50% patients were had the novel variants. You can see over here, this is all like the blue bars. This is the progressive familial intrahepatic cholestasis. Almost all types we had, and this is constitutes around 70% of this chunk. And next comes the bile acid synthesis defect, and few patients with neonatal sclerosing cholangitis and Alagille syndrome. And in all these patients, we did not find a single case of alpha 1 antitrypsin deficiency. And if you see the demographic and clinical characteristic, the consanguinity rate was approaching around 90%, and the family history of affected siblings was around 55%, and the major presentation was with the chronic liver disease. This one. If you see the biochemical characteristic, all these patients had cholestasis with deranged liver functions, and this is the parameter which was the most important panel. And you can appreciate that all these patients had low gamma GT except type 3 PFIC, neonatal sclerosing cholangitis, and Alagille syndrome. So rest all the conditions had low gamma GT cholestasis. So I'll just briefly discuss about few conditions which can present in early neonatal age or early infancy with the cholestasis. So this is the most common condition what we had in our cohort, the progressive familial intrahepatic cholestasis type 2. They usually present with jaundice and having pruritus, which is moderate to severe, with failure to thrive, and they present early with early liver failure and portal hypertension requiring the liver transplant. And this condition has low gamma GT cholestasis. So the next one is the type 3, although it presents in older age group more commonly, but it's also a differential diagnosis of bilirubin as well, and even you cannot differentiate these children on the liver biopsy from bilirubin. So genetic testing is required for diagnosing in these children. And the second important thing in this category is they usually do not have pruritus or have mild kind of pruritus, and they have high gamma GT cholestasis. This is the another category, which is the bile acid synthesis defect. We had 22 patients, and in these children, just keep in mind that usually these children they present with chronic liver disease, but they can present early on with acute liver failure, and their pruritus is also less as compared to progressive familial intrahepatic cholestasis. Either they do not have the pruritus or have very low kind of mild pruritus in these children. Next is the neonatal sclerosing cholangitis. We had 7 patients, and 2 patients presented in the neonatal age. The rest of the patients had the history of neonatal cholestasis, but they came to us at a little older age group. 2 siblings, they just underwent liver transplant recently, and they are doing well. This is the data of our from our study on the genetics and metabolic liver diseases in 2021. So what we figured out, the most common causes are genetic in our region. You can see over here, this is the genetic metabolic conditions, genetic cholestatic liver disease, metabolic liver disease, and this is the metabolic liver disease. And when we just compiled our results, the tyrosinemia is quite common in our society. Galactosemia, we had only 12 patients, and tyrosinemia were 17 patients. Recently, we were looking at the results, and we had more of tyrosinemia, around 27 patients of tyrosinemia, and the galactosemia were 15 only. And if we include this NPC, Niemann-Pick disease type C, the metabolic figure would be greater than the genetic cholestatic diseases. So we had more of genetic and metabolic causes of neonatal cholestasis in our region. So this is the paper published by Professor Huma recently in a very high impact journal, and it also showed that the high consanguinity rate, and there was a yield high in 60% of the patient. A genetic diagnosis was established, and it was more in consanguineous families. So, in summarizing my talk, neonatal cholestasis may be misdiagnosed as physiological jaundice, This may delay the proper management of the underlying disease and aggravates its complication. So differentiation between physiological jaundice and neonatal cholestasis, especially biliary atresia and other treatable conditions, is important to avoid the morbidity and mortality associated with them. In addition, parents must know when they should seek medical advice and when to suspect neonatal cholestasis. So this might be the time we need to just request our health department for the application of stool color card for screening bilirubin in our society. Inherited and genetic cholestatic disorders are not uncommon, presenting as neonatal cholestasis in the inbred communities like Pakistan. Rather, it's more common than the bilirubin as we see in the Middle East and Saudi Arabia. An accurate diagnosis will guide clinical decision, allowing for personalized medical management, monitoring, and more accurate prognosis. Thank you very much. If there are any questions.
Bismillah ar-Rahman ar-Rahim. We're ending this session, but before ending this session, I would like to congratulate all speakers for their nice presentation and who spoke with clarity and with prowess and competence, and they made the message clear. Of course, not forgetting the audience. They showed their enthusiasm, and their enthusiasm was impressive, and they kept session alive. Well, knowledge gained today, I'm sure, will enlighten all of us. For some of us, it is sensitizer. For some of them, it's advanced knowledge. And it will help managing our cases in our society in a better way. And of course, we must remember at the end of session, we must know what can we do, what cases can we manage, and when to refer to the experts, because experts are available also. And with this session, with these words, I close the session. Thank you very much, all. Thank you very much.
Thank you very much, sir. Now I would request our chairperson, Professor Tariq Bhatti, to please distribute souvenirs among our honorable speakers. So first of all, I would like to invite Professor Asim Makbool, who has traveled all the way from US to participate in this new colloquium 2023. Thank you so much, sir. Please receive your shield.